My name is Greg Perry. I'm the Pharmacy Clinical Manager, Inpatient here at Hendrick Medical Center. Our discussion today will be the penicillin allergy, facts, fears, and fiction. The penicillin allergy, in the spirit of full disclosures, there are no disclosures as it relates to this presentation. The objectives, or what we're going to try to accomplish over the next hour, is understand the epidemiology and the confusion surrounding penicillin allergies, the medical myths, if you will, or the misinformation that's out there, and not only discuss the penicillin allergy, but also the collateral damage that is associated with patients to themselves and others in many cases, as we talk about resistance in those individuals that report a penicillin allergy when it's really not true. Again, fact, fictions, and fears. We will do this looking at cross-reactivity amongst beta-lactams, looking at structure-activity relationships. We will look at how you can question patients, leading questions to determine is it real, is it not, and then follow up or finish discussing the penicillin skin testing process at HMC, at Hendrick Medical Center, and how we perform that and how you can consult a physician to do that. And then, of course, you always would be disingenuous not to follow up. Is there some legalities? Is there some culpability in giving a penicillin type or a beta-lactam antibiotic to a patient that does have a penicillin reported allergy in terms of legal issues or the negligence that could potentially go with it? I think it behooves us to discuss that as well. So jumping into the presentation, we'll start out with 3 case studies, and we will look at these again at the end. So case number 1, we have a 65-year-old male, 80 kilograms. They present to the ED with a 2-day history of fever and chills, worsening left forearm cellulitis with a surface area of 300 centimeters squared, so about the size of an iPad, with warmth and erythema extending from the wrist to the elbow with a grayish exudate. The patient does have a recent past medical history of left forearm cellulitis, which was unsuccessfully treated with trimethoprim sulfamethoxazole approximately 2 days ago. Current medications are Claritin 10 milligrams daily, so a non-sedating antihistamine, and the allergy history is penicillin. The patient states, I had some type of reaction when I was a teenager, but I'm not sure. I was told to avoid penicillin. So, case 1 continued. The patient was started on vancomycin, 1250, IV piggyback Q12, and meropenem 1 gram every 8 hours. The patient was sent to the OR for an IND of the abscess of the forearm, and a culture was taken along with blood cultures, and the abscess culture and the blood cultures, all 4 bottles or 2 of 2 sets, came back as gram-positive coxine clusters, and further sensitivities told us that it was methicillin-sensitive Staphylococcus aureus. So, case question number 1, what would you do? Would you continue vancomycin? Or letter B, choice B, DC vancomycin and begin nafcillin, 2,000 milligrams every 4. Patient has a penicillin allergy. Would you DC the vanco and the meropenem and begin cefazolin, 2,000 milligrams every 8 hours? Or DC the vanco and just keep the merom, 1 gram every 8 hours? So, case 1, more to the story. The attending physician, prior to changing the order, talks to the patient's wife, and she states the reaction was a rash of some type, but she is uncertain of the severity. So the attending decided to order a penicillin skin test for this individual. So a second question based on case number 1, based on the patient's medication history, there is no contraindication to penicillin skin testing. True or false? No contraindication to penicillin skin testing based on the history. Patient was taking Claritin 10 milligrams daily. Case number 2. 46-year-old male, otherwise healthy individual, presents to the ED with appendicitis, so this is not uncommon. Surgery is consulted. The patient is sent to the OR for a standard appendectomy. Past medical history, type 2 diabetic, has CAD. Current medications are metformin twice daily, atorvastatin 40 milligrams at bedtime. His allergy history is, up there it is, penicillin. Patient states that he had a reaction to amoxicillin when he was 16, which he described as a superficial rash without itching. The amoxicillin was given to him for presumed strep throat, but it turned out to be mono or mononucleosis, Epstein-Barr, viral infection, etc., etc. The surgeon orders cefazolin 2,000 milligrams times 1 dose stat, plus metronidazole 500 milligrams IV times 1 dose stat. This would be prophylactic. Surgical site infection prophylaxis for MSSA, E. coli, and Bacteroides fragilis, what you would expect in these type of situations. And 10 minutes after placing the order, the pharmacist calls and states, due to the penicillin allergy, the patient cannot have cefazolin. Would you consider ertapenem 1 gram IV piggyback times 1 dose in place of cefazolin and metronidazole? So case two question, what do you say? A, sure, change it. What will it hurt? Meaning change to ertapenem. Answer B, no, that is what I want. The actual risk of a penicillin allergy being real with cross-reactivity is less than 1%. I'm okay with this. Besides, it was probably the mono-amoxicillin combo. And then the third selection, physician response. I heard penicillin skin testing takes only 1 to 2 hours. Let's do that. So case number 3, 42-year-old man presents. He has some progressive dementia, movement disorders manifesting as myoclonius, etc., some Parkinsonism. His mini mental status exam score was 12 of 30. After excluding different neurodegenerative causes, further diagnostic testing was consistent with neurosyphilis, which we know the treatment of choice is penicillin. The patient's mother informs the ID physician that her son is allergic to penicillin, and this occurred in his early 20s, and he had trouble breathing with a rash, but it self-resolved. So case 3 question, or what is your next step as a physician? Choice A, penicillin, 4 million units IV every 4 hours. Just go ahead and go straight to the penicillin. Choice B, perform a penicillin skin test, then proceed with therapy. Choice C, patient should be desensitized to penicillin, or a second line option, begin ceftriaxone 2 grams IV daily. So those were the case studies. We will review those at the end of the presentation. So let's just talk about stewardship in a very general sense. Certainly, when we talk about stewardship, the 3 R's are our main points we want to make. The right drug, the right dose, or the right length of therapy. And in the case of the neurosyphilis, the right drug is penicillin, but the patient listed a penicillin allergy. Now again, sometimes the right drug is no drug at all, but when we talk about stewardship, that simplifies it in 3 easy to remember phrases. Right drug, right dose, the right length of therapy. So let's talk about the penicillin allergy, the facts, and the fiction, and the fears. The next 4 or 5 slides, we'll discuss this. So the facts, 10% of the U.S. population reports having a penicillin allergy. That's a true statement. What else is true is when you do a true evaluation, less than 1% of that 10% actually have a type 1 IgE-mediated penicillin allergy, meaning the allergy is fictitious, it's bogus, it's false. Of that 1% that does have a true allergy, 80% of these patients, 80%, 8 out of 10 that have a true allergy, will actually desensitize after a 10-year period. So if they have a true IgE-mediated penicillin allergy, a type 1 allergy, they'll lose that sensitivity after 10 years. So even if it was a true allergy, the likelihood of it still being there is slim to none. A 20% chance that it's still there. And then, of course, the Epstein-Barr virus infection that we see a lot in our teenagers and younger individuals receiving amoxicillin or ampicillin, that can actually interact with the Epstein-Barr, leading to a non-allergic, non-pruritic rash. That's important. It does not itch. Will look similar to in a type 1 reaction, in type 1 IgE-mediated reaction, but it's not. It's not an IgE response or reaction to the penicillin. So, we're not here to have an immunology lecture, but just to give you a brief overview. As you remember from that course that you had, whenever it was, 4 types of reactions. Our discussion is going to revolve around the type 1 reaction, which leads to anaphylaxis in some, less than 1%, less than 0.5%. But that's what we're discussing, IgE-mediated, basophils, mast cells. That kind of plays into the question about the gentleman taking the antihistamine, the Claritin, right? And of course, its presentation is itching and potentially anaphylactic reaction, which can include at least 2 of 4 main organ systems. But that is our focus for this discussion. So, the problem when we utilize broad-spectrum antibiotics as an alternative to narrow-spectrum penicillins and cephalosporins in patients labeled penicillin allergic, and we see this often, and the most common substitute for a patient with the penicillin allergy, unfortunately, is a carbapenem, which in and of itself causes collateral damage, because those are the most profound, biggest inducers we have. And that leaves everything else resistant over time. It's a paradox. The miracle destroys the miracle. But giving a patient a drug such as meropenem just because of a penicillin allergy when they could have a drug such as penicillin or Unison, ampicillin, sulbactam, etc., why would you want to increase the burden of potential resistance or selective pressure? So what overall do we know that creates when we label someone with a penicillin allergy? Their therapy is altered because of that. Well, we know it increases the healthcare cost, and it certainly increases the risk of resistance, both selective and induced. And again, meropenem, carbapenems in general, ertapenem, imipenem, they will induce your space pathogens, your Serratia, your Proteus vulgaris, your Acinetobacter, the Enterobacter species, so on and so forth, Morganella morgani, the list goes on. They will induce that, not their own resistant, but resistant to 3rd-generation cephalosporins, 2nd-generation cephalosporins, aminopenicillins, and you can see the problem that will create. Over time, that creates a selective pressure due to inducement. The third issue is suboptimal antibiotic therapy, and we'll discuss that. There is collateral damage. We know that your risk of mortality if you declare a penicillin allergy increases. We know your risk of tough-to-treat multi-drug resistant pathogens increases when you declare a penicillin allergy. So it behooves us to find a way to establish, is the allergy real? Is it not? And move forward. And we have those options, and there's no better place than a hospital to test these hypotheses or these declarations of a penicillin allergy. So looking at the whole combating resistance. So part 2, we said increased risk of resistance. Well, let's just see what that means. So what literature tells us is a patient claiming to have a penicillin allergy compared to control subjects. When we talk about the Centers for Disease Control and the biggest threats to our health, MRSA, VRE, and Clostridium difficile, or what they call now Clostridioides difficile, are 3 of the biggest threats among 3 or 4 others. But in the case of this discussion, let's just look and see what the collateral damage is. So those who claim to have a penicillin allergy have a 23% higher incidence of C. diff. 23%, that's 1 in 4. They have a 14% higher incidence of methicillin-resistant Staph aureus and a 30% higher incidence of vancomycin-resistant enterococcal infections. Those are big numbers. It's anywhere from 14 to 1/3 of patients in this regard. And we know that antibiotic-resistant infections is a burden on the U.S. healthcare system in excess of $20 billion every year. So when we talk about these medications that we may go to, so a patient declares a penicillin allergy, we'll give Rocephin. Well, let's just think about that. What are the biggest inducers of let's use VRE, vancomycin-resistant enterococci? You think, oh, vancomycin induces that resistance. No, wrong. It's 3rd-generation cephalosporins, and you can see there vancomycin-resistant enterococcus. Extended-spectrum beta-lactamases, including those Klebsiella species such as KPCs or ESBL, E. coli infections, and then, of course, Acinetobacter species. Quinolones, they're associated with inducing methicillin-resistant Staph aureus. A quinolone has nothing in common with the beta-lactam, but yet it actually induces the resistance of beta-lactams, making drugs like nafcillin, oxacillin, methicillin, cefazolin no longer a utility for treating staphylococcal infections. And then, of course, the quinolone-resistant gram-negative bacilli, which goes without saying. If you look over it from a national perspective, the resistance rate is anywhere from 30 to 40% against our coliforms, which is certainly a concern and certainly an issue. So, other collateral damage. Let's just talk about C. diff. Previous slide that we went to, 23% higher incidence of C. diff. Well, let's just say you can treat a patient with neurosyphilis with penicillin or an MSSA bacteremia with cefazolin or nafcillin. Those are going to have minimal effects on the normal flora of the large bowel. I use this slide as an example. You can see, if this is the gut, you can see the healthy microbiota. These are the good bacteria, so to speak. You can see when an antibiotic is administered on the right side of your screen, you actually create dysbiosis or disruption of the normal flora, right? So when you have that disruption, that exposes the lumen of your GI tract to other pathogens, in this case, Clostridioides difficile, and that can lead potentially to CDI. And that can be anywhere from mild to major, even death, with a toxic megacolon and profound colitis. So this is just an example. A picture's worth 1,000 words, but you can see when you have a declaration of a penicillin allergy and you go from drugs that are targeted therapy to those who have broad spectrum coverage, such as meropenem or rocephin, you will create dysbiosis in the GI tract or disruption of normal flora, and potentially, if the patient is colonized with C. diff, create a situation in which now the C. diff is not communal, it is now pathogenic, and that just creates a second problem to deal with among the primary infection that you're trying to treat. So, the penicillin allergy and surgical site infection. So again, talking about collateral damage. So this is a study by Blumenthal and colleagues. It came out of CID in 2018. So hot off the press in February this year. 8,300 patients, over 9,000 surgical procedures. These included knee replacements, hip replacements, gynecological surgeries, general surgery such as a colon resection. Patients reporting a penicillin allergy who received a non-beta-lactam. And at Hendrick Medical Center, what you'll see is clindamycin plus flagyl, vanco plus flagyl, or gentamicin as a perioperative antibiotic, depending on the surgery. If it's a knee, you'll see clindamycin or vanco replaced for it. If it's a gastrointestinal surgery, you'll see an ertapenem. There's others, but in this study, those who received a non-beta-lactam, clinda, vanco, or gentamicin, what they found is your adjusted odds ratio was 1.51, meaning the odds of a surgical site infection increased by 50% in those patients who declared a penicillin allergy and received an antibiotic other than a beta-lactam, cefazolin, cefoxitin, cefotetan. To put it in a more simple perspective, the numbers needed to evaluate to prevent one surgical site infection would be roughly about 110 to 120 patients with the penicillin allergy. So when we do 60 to 70 to 80 procedures a day in an institution, we meet that 100 threshold. One surgical site infection can be detrimental not only from an economic perspective, but also to the patient from a morbidity and possibly a mortality perspective. So again, it's good to know if the patient has a true allergy or not. We're going to discuss how to discern that in the next few slides. So when you look at continuing on the collateral damage, beta-lactam allergy in the hospitalized patients with a hematologic malignancy. Very interesting study. This came out of CID as well. What they found is 4,600 patients that had hematological malignancies. Roughly 14% listed a beta-lactam allergy. For simplicity, we'll call it penicillin, but the study was just a beta-lactam allergy indifferent. What they found in those patients who had the declaration of a penicillin allergy is that their length of stay was 11.3 days versus those who did not have a declared beta-lactam allergy of 7.6 days. The 30-day mortality in those who carried a penicillin allergy was 15.8% versus 7.6%. You see the problem here. Having a penicillin allergy when you don't truly have one can be life-threatening. So your 30-day mortality, your 180-day mortality, not as profound as the 30-day, but still 15.8% versus 12.2%. Of course, the proverbial readmission rate at 30 days, pay for performance, 19.2 versus 15.1. The C. diff rate, which we already discussed in a previous slide, on those who declare a beta-lactam allergy or penicillin allergy, substantially higher. And in this case, the study just supported that 18% versus 11.5. And when you look at the total burden on the healthcare system, it's almost, or it is, a $50,000 difference in the cost of care for those patients. And certainly it ties into length of stay or the length of therapy of these patients, which will directly correlate with the length of stay, 11.3 days versus 7.6, and then the length of therapy of those antibiotics, 9 days versus 6 days. So one thing we do know is the best group of antibiotics we have are the beta-lactams. They're the most dependable, they're the most reliable, they're the easiest to predict what you have to dose, pharmacodynamic principles, in order to potentially have the probability of a positive outcome. We can't really say that with any other class of antibiotics, so you don't want to eliminate beta-lactams based on a comment of, I have a penicillin allergy. When did you have it? 60 years ago. Who told you? My mother. You don't want that. That right there are key words to investigate the allergy even further. Now, it's a penicillin allergy. We have other options. I think we proved over the previous 3, 4, 5 slides that it is sinister, it is detrimental potentially to the patient, and it behooves us to investigate it and find out, is it real or is it not? Is it fact or is it fiction? So, the solution: correctly identify if a patient is or is not penicillin allergic. Now, how do we do that? Most of the time, it can be done with a history and physical, specific to the drug reaction. Second is understanding the structure-activity relationship. Now, this gets academic, but just know this is more bench material, but it is certainly something that is applicable to the bedside. And then when all else fails, the penicillin skin test, and we'll discuss that in regard to how we do it at Hendrick Medical Center, who can do it at Hendrick Medical Center, and who in the outpatient setting you can send your patients to have the test performed. So let's start with the history and physical. So leading questions, simple questions. What medication were you taking when the reaction occurred? A lot of times it's elderly people, they'll say, I was taking a pink liquid, amoxicillin, or they had penicillin, something along those lines. What kind of reaction occurred? Well, I had a rash. I had a stomach ache. I don't know what my reaction was. My mom just told me I was allergic to it. Those are all key words that make you think, I don't think you have a reaction. And if they're 60, the reaction happened when even when they were 10 years of age, even if it was a true type 1 reaction, even if it was true, remember, 80% of patients will self-desensitize over 10 years. So the odds of them having an infection is decreased substantially. Then, of course, how long ago did the reaction occur? That ties into that 10-year situation. How was it managed? Well, they had to intubate me. That's a red flag. That's a concern. You'd want to take that into consideration, and then what was the outcome? So we look at the history and physical, the characteristics. So when you ask the question, well, what type of reaction did you have? Now, knowing a type 1 IgE-mediated reaction is going to be less than an hour, so immediate in most cases, and you will have hives, and it will be pruritic. You will be itching. You can have angioedema, which is a fluctuation or a movement of fluids into tissues, and of course, if that's up around the lips and the mouth, that can certainly get in the way of the airway or block the airway. Wheezing or shortness of breath. When we talk about anaphylaxis, the true rate of anaphylaxis, we hear the term used a lot. It's kind of like sepsis. We see it used inappropriately a lot of the times. in terms of the actual definition, but anaphylaxis is the same. The rate is only up to about 0.05%, and in order to call it anaphylaxis, you have to have at least 2 organ systems involved. It's going to include the skin, the respiratory tract, cardiovascular, the GI, so nausea, vomiting, diarrhea. From the CV perspective, tachycardia, hypotension, chest pain. From a respiratory perspective, cough, congestion, shortness of breath, etc. And then, of course, for the skin, hives, flushing, itching, and then angioedema. So the second part, after the history and physical, if that's not enough to come up with a conclusion, or that's not enough to answer your question, do you or do you not have a penicillin allergy, is to think about the structure-activity relationship, or what we call the SAR. Now, when we look at cross-reactivities, and this will tie into this whole structure-activity relationship, historically, what I was taught in school and what many physicians are taught in school is that if you have a penicillin allergy, your cross-sensitivity to cephalosporins is roughly 10%. Now, we know that's false. Penicillin and carbapenems is 5%. We know that's actually probably 0%. And then if you have a cephalosporin allergy, the risk for a carbapenem allergy is roughly 25%. Now, we know these numbers are inflated. We know that they're false. We know that they're fiction. So this slide here, what does this have to do with the penicillin allergy? Absolutely nothing. Why did I put this slide in the discussion? The takeaway point is this: as we talk about structure-activity relationships, the point is not for you to have to go home and memorize the structure of a bunch of beta-lactam antibiotics. The whole point is to understand the concept. At once upon a time in all of our careers, we had to memorize the citric acid cycle, regurgitate it on a test, when all we really needed to know is what does it stand for? How do you assess it? That's what we're looking at from a structure-activity relationship. It's not knowing the structure of these drugs, just like it's not knowing the citric acid cycle. It's comprehending or understanding the concept of the point of this process. And then in the case of the structure of a drug, how does the structure of a drug in general affect your cross-reactivity as it relates to a penicillin allergy? So let's talk about the beta-lactam ring. And I'm going to jump to the next slide quickly so you can see this is the penicillin up here in the top left corner. This ring, the beta-lactam ring, is what is your killing component of a beta-lactam. That is also a target for resistance. Beta-lactamases cleave this and expose it. It's exposed, and then the antibiotic is rendered useless. So what we look at when we look at the antigen or the epitope, what has the antigenicity? It's all based on this R1 group, this functional group that comes off. You can see for the cephalosporins, you have the R group there. Come down to the monobactams, there's your R group. And of course, when you look at carbapenems, the R1, there's your R group. So going back to the previous slide, when we think about structure similarity, that does not equal cross-reactivity. And again, as I stated, we look at where the epitope is, the epitope being the antigenic part of the molecule. That is what creates the allergic reaction. And so we look at similar R groups, not similar structures in general. So when you look at cross-reactivity, the first point will be first-generation cephalosporins. Your cross-reactivity with penicillin allergic patients is roughly 5% or less. Now, I can tell you right now that 5% is going to be due to cephalexin when you have a true penicillin allergy, or cefadroxil, not cefazolin. The second-generation cephalosporins are higher. Let's talk about that. You have a penicillin allergy. You're probably not going to react to cefuroxime. You probably will react to cefaclor, and we will discuss that. And again, we're looking at the R1 groups. That's what we're looking at. That's what we're seeing for an antigenic component. Now, again, you don't have to memorize all these structures. That's ridiculous. So let's just look at the side chain, the elements, the components. So this is a study out of Italy, a very nice study, outpatient clinic in Italy, 214 patients with a documented hypersensitivity reaction delayed to penicillin. These patients underwent skin and patch testing, and what they were found is no reaction to the second-generation cephalosporin, cefuroxime, the third-generation cephalosporin, ceftriaxone, and the monobactam, aztreonam. None of the 214 had a reaction. 40 of the 214 did have a reaction to the cephalexin, and that was 31 of the 40. Similar ampicillin side chain, first generation cephalosporin. No reaction to the second generation cephalosporin cefuroxime up here. When you look at the second generation cephalosporin cefaclor, 39 of 40 had a reaction. So both are second generation cephalosporins. They only reacted to the cefaclor. It relates to the structure-activity relationship and the R group. And then following up with the first-generation cefadroxil, again, almost half had a reaction that had true penicillin allergy. So that kind of gives you a study that supports the premise that it's not the generation, it's the structure similarities. This study here in 2015, same concept, same premise. 212 penicillin patients who were skin test positive. They had a history of anything from just redness all the way up to anaphylaxis. Of those who were tested for carbapenems, zero of the 212 had a positive skin reaction to carbapenems. Hence the reason you see so many times you have a penicillin allergy. Oh, let's just give a carbapenem. But again, we already discussed the collateral damage that is created by the overuse of meropenem. And I can tell you that the sensitivity of meropenem to Pseudomonas at Hendrick Medical Center as at the end of 2018 is only about 84 to 85%. So that's right there in and of itself should be an alarm to those who are prescribers and treaters of these infections and the utilizer of these antibiotics. So we go to the structure-activity relationship, just a case study embedded. So we have a patient that has a Staphylococcus aureus bacteremia, pan-sensitive, including the drugs of choice, nafcillin and cefazolin. When we talk about methicillin-sensitive Staph aureus, there is no better choice of drug than nafcillin or cefazolin. As I like to tell my residents, the top 10 drugs for treating MSSA bacteremia, it's very simple. Number 1 is nafcillin, number 2 cefazolin, number 3 is nafcillin, number 4 cefazolin. I think you get the point. So patients that list an allergy to penicillin, you can see the problem there. You're going to avoid the 2 drugs that give you the best outcome proven in the literature. In this case, the physician elects vancomycin, which we know is more toxic and expensive, or you could go with linezolid, again, more toxic and expensive. So in the case of this, patient has a penicillin allergy. Is nafcillin or cefazolin an option? Why or why not? The answer is it is, and let's just discuss it. So there's your general R1 group of penicillin. Again, it's similar, penicillin G, V. There's nafcillin. So by default, if you were just looking at that, I would go ahead and exclude nafcillin. Just take it out of the picture. What about Keflex? Now, I realize you're not going to use Keflex for an MSSA bacteremia, but for the sake of this discussion, would you use it if it had an IV formulation? And I think when you look at that R group of Keflex compared to the epitope or the hapten of penicillin, your answer would be no. But look at cefazolin. This would be okay. It's not, doesn't have the epitope, the hapten, the antigenetic R1 group that we would expect to cross-react in a patient with a penicillin allergy. So my point being is cefazolin would be a safe option in this patient. So, second case, Streptococcus pyogenes, the most common is group A strep in our beta hemolytic category. It's the most common pathogen for erysipelas skin infections. No, we typically can't culture it out because we typically don't have purulence with it. But you get the point of this. The patient is allergic to penicillin, and the physician elects to use cephalexin, right? You could use penicillin if they weren't. You could use Keflex if you wanted to. There's multiple options, but in this case, the patient has a penicillin allergy. So is the cephalexin an appropriate choice? And the answer is no, it's not. And the reason being, again, going back to the premise of the structure-activity relationship versus the R group, what is the antigen? In this case, you can see penicillin G or penicillin V. This is the groups we look at. You look at Keflex, very similar. You'd probably want to avoid that, right? What about cefazolin? Well, you could, but this patient's in the ED or your office, your practice. You're like, come on, I'm not going to give you IV antibiotics for this. So, you know, but just for discussion, you could, but let's knock that out. Okay, well, you're out of options. Could you use second-generation cefuroxime? Well, we already discussed it in that Italian study out of CID that none of the patients that had a true penicillin allergy reacted to the second-generation cephalosporin, cefuroxime. That wasn't the case for the second-generation cefaclor, and it's very similar to the penicillin at its R1 group. So a physician could actually use something other than doxy. Many times the go-to is Bacterem, but the problem with that is Bacterem has horrible streptococcal coverage. Whether it's group A strep, Zithromax, a Z-Pak, horrible streptococcal coverage. Resistance rate as high as 30, 40, 50%. So why do you even want to try it when you know that beta-lactams are your best antibiotic for treating erysipelas, just as penicillin for neurosyphilis in one of our cases? So Ceftin would be an appropriate choice, 500 milligrams a couple of times a day for 7 to 10 days, and you're good. So it's hard to see on this slide, but it just depicts the functional groups. Again, I'm gonna point out cefaclor. You can see it there. There's cefaclor, and then there's cefuroxime. You can see cefaclor mimics penicillin. You can see it, where cefuroxime does not. But this is it's just a general schematic of the drugs that would potentially cross-react. So the solution, so we talked about the history and physical, we talked about the structure-activity relationship. Let's talk about the penicillin skin test, which you can do at HMC. It is approved. It's a P&T, a PI, and MEC approved policy and procedure. It's in place. We've been doing it now for a couple of years. Now I have a slide that explains how many we've done. I believe it's 4. I can tell you we've done 8 penicillin skin tests inpatient to date, and none of those have been positive. And I'll explain that process to you. You would think if you looked like the numbers needed to harm, it would probably come out to about 1 in 50 who declare a penicillin allergy should potentially have a positive skin test. So anyway, our N is 8, and to date, they're all negative. So anyway, yes, you can do it here. And the intent is for inpatient utilization to direct inpatient selection. I'm going to give you an example. A patient declares a penicillin allergy. They have Enterococcus faecalis in the blood. It's currently being treated with vancomycin. Why? Why not do a penicillin skin test and just use ampicillin? Less toxicity, nephrotoxicity, ototoxicity, etc. That would be a classic example to do a penicillin skin test on. If it's negative, give them ampicillin, not vanco. Forget the levels. Just do 2 grams Q4 instead of vanco 1 gram Q12 or Q8, serum creatinine 3 times a week, a vanco trough every 5 days, so on and so forth. You get the point. But anyway, we use it on the inpatient side to direct inpatient therapy. Now, the question is who can do it? There's the policy states that if you're not an allergist, only infectious diseases can do it. And that's going to be Dr. Daniel Canario or Dr. Yamanakali. Or an allergist. The only allergist I'm aware of locally that does these at has privileges at the hospital is Dr. Ashley Hall. She can also be consulted to come into the inpatient setting. Now, for the outpatient setting in regards to penicillin skin test, do not refer them to Dr. Canario or Dr. Kala. Their practice, their offices, their clinics are not set up to handle that. You would really want to send those to Dr. Ashley Hall, who does those in her office and is a true advocate of trying to figure out who does or who does not have a penicillin allergy for the reasons I've already stated in this discussion. So how do we do it? First, we look at the potential benefits. 1, combating drug resistance. I think I outlined that nicely of the issues with C. diff, MRSA, vancomycin-resistant enterococcus, etc., in patients who declare a penicillin allergy. Whether true or not, and it leads to avoidance of beta-lactams. The cost of care reduction, we saw that in the hematological malignancy case or journal article. And then, of course, you have full support from the antimicrobial stewardship team. What I mean by that, if Dr. Hall, Dr. Canario, Kala, when they do these tests, pharmacy sets it up 100% for the physician, and we actually sit with the patient for the 15-minute intervals before interventions. We'll discuss that shortly. So we look at the cost reduction. Now, we do know that the high cost of broad-spectrum agents in patients who have a stated penicillin allergy, so you can look at a mean antibiotic savings of roughly $297 per patient. Those are just hard cost dollars. You can't really get the intangible cost to a penicillin allergy when we talk about resistance, when we talk about surgical site infections, when we talk about hematological malignancies and associated infections, and the morbidity, mortality, the length of stay, the length of therapy. But in general, you're looking at $40 a day average cost of therapy for a penicillin allergic patient before skin testing versus after skin testing. It drops down to $18. How accurate is it? It's a nice question. So sensitivity's up there. Again, with sensitivity, we're ruling out disease. With specificity, we're ruling in. But there's greater than a 95% negative predictive value when skin testing with the major and minor determinants or the antigens. We do not have major determinants in U.S. penicillin manufactured, sold, distributed products, but that is part of the testing. And that's appropriate. You need to have the most antigenic part of penicillin in order to determine your allergy or not, just not minor determinants. But if you give the oral challenge, which we do, it approaches almost 100%, meaning it's very specific for ruling, or sensitive, I should say, for ruling out disease and specific for ruling in. If you test positive with the initial go-around, you probably have a penicillin allergy. That's when we start talking about desensitization, which is another discussion for a different day. So from a stewardship perspective, we know penicillin in skin testing improves antibiotic selection and stewardship in the hospital setting. I gave you the examples of an Mssa bacteremia and using Vanco, or a true case that we've seen just recently, Enterococcus in the blood, penicillin allergy, when we could be using, or declared penicillin allergy, not proven, we could be using something like dirt cheap ampicillin and not the nephro-ototoxic vancomycin and all the monitoring. And then, of course, we know that if you have a penicillin allergy, we're going to see more carbapenem use, more Clinda use in the OR, Vanco and fluoroquinolones as well. So the necessary reagents. So we have a histamine. This is for your positive control, and this comes into the patient we discussed earlier. He took a Claritin. That would interfere. If you've taken a non-sedating antihistamine in the past 7 days, you probably need to wait to do the test. You could try it, and if the histamine control is positive, then you can proceed with the rest of the test. Now, Benadryl, diphenhydramine, that's more of a 24-hour scenario. What about steroids? They do not interfere with the test if it's normal, low dose. An extremely high dose steroid, possibly, but that's something to keep in mind. Steroids do not get in the way. The second is just saline. That's a negative control. Then we have the pre-pen ampule. This is the major determinant, which is not part of products available in the U.S. market. This is your epitope, your hapten, that is the most antigenic. We use that, and then we just make up a diluted penicillin G IV, diluted to 10,000 units per mil. That's the U.S. available product, and that is our minor determinant. So again, the pre-pen, this isn't to be commercial or have bias. This is, at this point in time, the only product on the market. That's why we are okay using the proprietary pre-pen name. So this is not a declaration of we support this product. It's the only product available that gives us the major determinant. But that's what we use. So here's your products. You can see your histamine control. There's your pre-pen, or your major determinant. So histamine control, major determinant. This is a vial of just penicillin, good old penicillin. Your minor determinant, and then there's your saline control. So you have an active control and an inactive control, and then of course you have your two active products. So there's the penicillin skin testing kit. Comes with everything you need in it. Again, pharmacy shows up at the bedside with this kit, with all the drugs, with all the syringes. The physician just needs to show up and do it. We'll even put the notes in the chart documenting each stage and each reaction and measurements along the way. So first thing we do is step one, the skin prick test. This is very simple. You make 4 areas just on the forearm. You want the pre-pen. You want which is going to be your major determinant, your penicillin G, your minor determinant, and then your saline control and your histamine. So you put 1 drop of those on each little area that you mark on the forearm. And you just do a little skin prick. and you wait 15 minutes, and then you see what is your area of not erythemia. You don't really see redness per se. Sometimes you do, but the induration, how does it expand? Because remember, this is not a bleb. That's on part 2 or step 2. This is step 1. This is just a skin prick. So after 15 minutes, if that is negative, you can go on to step 2. This is the intradermal test. Now, you would never give histamine intradermal as a bleb. That could actually lead to a pretty serious reaction from a skin structure perspective. So that we're done with that. What we do is we go to the forearm or the shoulder. You could use the other forearm if you wanted, but this is what they recommend. And we prepare the skin, you clean it with an alcohol swab, you make your marks. And what you do is you label it appropriately. But what you do is you do 2 blebs. A bleb is just a subdermal, just like you get with the TB test every year. You do 2 of the prepins, the major determinant, 2 of the minor determinant, the penicillin G, and 1 of the saline. And as you do those blebs, roughly 3 millimeter blebs, you circle them with a marker or a pin, and you wait 15 minutes. And if the bleb has moved outside of your line of demarcation of your induration, more than 2-3 millimeters, you can consider that bleb positive. So if you're seeing that on the prepin or the penicillin G, you could consider that a positive test. Now, you're going to stop right there. If it's negative, and some say you do, some say you don't, here at Hendrick Medical Center, we do the oral challenge. What we will do is we will then give the 250 to 500. But this final interpretation, you can see a positive reaction with the blebs. It's obvious. You can see where they marked the area of the bleb, and then you can certainly see the induration that moved outside of the margins. And then a negative skin test, there is no progression outside of the marked margin of the bleb, meaning there's no induration, so there's no reaction. But if you get through all that, there's an optional oral challenge. Now remember, you already have a negative predictive value of 95% or higher. When you add the oral challenge, you get right up next to 100%, so why not do it? We will give a 250 milligram dose of penicillin, amoxicillin, ampicillin, whatever it may be, and then monitor the patient for at least 60 minutes. And if no reaction occurs, you can declare them as not having a penicillin allergy. The physician has to remove it. That's going to be a physician assessment, but the physician can remove it, and then the patient from that point forward does not have to worry about being restricted. And the physician as well, it reintroduces autonomy to the physician in regard to the antibiotics they can select to treat their patients, and literature tells you treat your patient better. So when we do this, patients are ecstatic to find out that they don't have a penicillin allergy. So it's good for the doctor, it's good for the patient, it's good for everyone. So something to consider. Again, inpatient, Dr. Hall, Canario, or Kala. On the outpatient side, please do not send them to ID because they're not set up to do that. You need to send them to an allergist. And again, the only one I'm aware of in Abilene proper is Dr. Hall, but any allergist can do that. I'm not trying to represent one physician over the other. Any allergist that's in town or in the region or another city can carry out these tests, and probably will be happy to do it because they see the same things that we're discussing right now. So who should get a penicillin skin test? Well, with most things, it's for those 18 years or older. If you have a history of a reaction to any penicillin antibiotic, I'd even go as far to say a recent history of a reaction to any penicillin antibiotic, or if it's a distant reaction, what kind of reaction did you have? If they say they went into anaphylaxis, stopped breathing, and had to be tubed, that's going to be a red flag. I'm probably not going to try to re-challenge anybody. Those who have a penicillin or antibiotic is the drug of choice for treatment in the patient, that's going to be a neurosyphilis patient or an enterococcal bacteremia. And then, of course, the patient verbally consents to having the procedure done. What are some of the contraindications? What you would expect with any type of antigenicity testing, allergy testing. Does the patient have a history of Stevens-Johnson syndrome? Do they have a history of TN? Serum sickness, interstitial nephritis, hemolytic anemia. Now, this is getting into the type 2, 3, and 4 reactions as we discussed the immunology of a reaction. allergic reaction. But again, you don't want to take that chance. A drug rash, penicillin reaction in the last 5 years. Again, that's when did you have your reaction? It was 50 years ago versus, well, it was yesterday. You certainly would assess those differently. A pregnant or nursing mother, because you're dealing not just with the mother, but with their child as well. There's the take-in diphenhydramine in the last 24 hours, all others the last 5 days. I stand corrected. I think I said 7 days, but the gentleman in the case study that we discussed had taken Claritin daily. And then, of course, those who have severe immunosuppression, but this does not include glucocorticoids, and that's something to keep in mind, because a lot of our COPDers may benefit from a beta-lactam antibiotic, but of course they're getting the prednisone 40 daily as part of their gold therapy or recommended best practice, so to speak. So how to order requires, again, an allergist or an ID consult. You just put it in there and specify penicillin skin testing. Again, pharmacy, we will prep all the reagents and supplies, and the physician just tells us when to be there, and we'll be there waiting in the room to assist them to expedite getting the process starting and getting them done and on with their day. Again, we sit in the room. That allows the physician, he or she, if they want, can sit in at the nurse's station and chart on patients or even go see another patient. But we sit there with the patient. Results at Hendrick Medical Center, these are dated. We have now done 8 tests, and we have 8 negative. All of the patients were changed to an aminopenicillin or a penicillin, meaning ampicillin or the ampicillin-sulbactam combo of unison, or just straight penicillin. But we've had 0 positive and 8 negatives to date. So let's talk about, again, I said at the first, it'd be disingenuous to have this discussion and act like that it's all fair game and there's no issues or there's no risk with it, because that's not necessarily true. What this slide depicts, and this was a nice slide by colleague Megan Jeffries. She presented this at the SIDP meeting in 2016 at the ID week in San Diego, California. And what this represents, the solid black line is the total number of cases or lawsuits filed on patients with a known penicillin allergy who experienced an adverse reaction. And then your dotted line, your dashed dotted line, represents the cases in which the defendant prevailed and then where the plaintiff prevailed. Now you can see the decade between 2005 and 2015, we had roughly 7 cases, 7 litigated cases, where it looks like about 4 of the patients, 1 prevailed and 2 or 3 did not. So what's the takeaway there? Again, I don't know the specifics behind each of these cases and what was or was not, was something malicious or malice, I don't know. But you do want to assess the penicillin allergy and not just in certain cases assume, oh, it's not there. Again, I think if you're talking to someone in the hospital, these weren't all inpatients, and they're 75 years old and they had a penicillin allergy when they were 5, as reported by their mothers who have since passed, and they don't know, even if they did have a penicillin allergy, the odds of them still being sensitized to those epitopes or those haptens are slim to none. I think that's someone you could challenge. If it's a 25-year-old who had it when they were 16 and did not have mono with it, that is a case where you could say, you know what, maybe we do penicillin skin testing. That's going to be up to the individual physician to discuss. And again, one of the cases I found that stands out, this is Boone versus Williams. So the 4-year-old boy Boone, he presented to the ED with signs and symptoms of otitis media. Now, you could go into the argument, I read part of the case, should you treat that or should you not? Being a 4-year-old boy, a unilateral issue without bulging of the tympanic membrane, would you extend an antibiotic even to that patient? Now that gets into the whole thing of stewardship, but for this case, he was treated with Rocephin IM as an injection. He did have a listed penicillin allergy and he did have a sulfa allergy. Now his reaction was immediate. So in the ED, he had vomiting and sweating and became pale. Now again, that's going to represent the vomiting. We talk about anaphylaxis, so that's one organ system, the GI tract. The sweating and became pale, I'm not sure if that would be CV or not from a dilatory perspective. But the nurse stated that the symptoms is caused by the injection. And it's safe to take young boy Boone home. So the mother did, but outside the ED, the child began to vomit violently. So the mother went back to the ED and requested help and was turned away per the case. And then, of course, at home, the vomiting continued, and then the lips and gums turned white. They returned to the hospital. Young Boone was lethargic and non-responsive, and unfortunately, the young man passed away that night. But when they did an autopsy, they found it was hemolysis due to an allergy, a reaction to Rocephin, but a type 2 allergy. So I think it's important to understand. But in someone that young, if they have, and my point being, if a penicillin allergy is declared in a 4-year-old, it's probably a good idea to follow up on it and not just give a beta-lactam antibiotic. Therefore, the mother's going to be well aware. But even in this case, the outcome, the motion, the defense successfully moved for summary judgment, and the plaintiff appealed the case to the Connecticut Supreme Court, and the court upheld the trial court, saying that the ED staff was not culpable. So this is a very, very sinister case to discuss, but again, I think it kind of gives the science that's out there. Now, again, there's other options. I'm not here to assess was cared right or wrong. The case is out on the internet. You can find it and review it. But again, you want to say all these good things about penicillin skin testing and do this, they're not penicillin skin testing or using it without skin testing, but there is potential, albeit little, slight, not much at all, but there is potential for some culpability if something does go wrong. But again, it goes back to those 3 components. You want to take an appropriate history first. If you don't discern what you want from that, certainly go to the structure-activity relationships, and if that doesn't work, your penicillin skin test is your 3rd option. And that's certainly going to be definite, almost 100% sensitivity. So back to our cases, 1, 2, and 3. So we had our 65-year-old gentleman came to the ED with some cellulitis, ended up with MSSA in his blood and in his wound. So he's going to need probably 14 days of IV antibiotics for his MSSA. So again, he was on Claritin, was started on vancomycin, Q12, meropenem, 1 gram. I agree with the vanco, again, not to go off on a tangent or chase a red herring, but why would you add meropenem, 1 gram Q8, to a skin-skin structure infection with purulence, knowing that 99% of the time that is going to be a staphylococcal infection, and 50% of the time at least that's going to be an MRSA infection. The treatment of choice to start with anyway is vancomycin. You don't need the meropenem because the risk of a pseudomonal infection is slim to none. So anyway, this gentleman went to the OR. He did have blood cultures drawn, and he grew in all 4 bottles gram-positive coxine clusters, which was later identified as methicillin-sensitive Staph aureus, and that also grew in his wound as well. So the question was, what would you do? Would you continue vancomycin? He has a penicillin skin test. Would you DC that and begin nafcillin, DC the vanco and the meropenem and begin cefazolin 2 grams Q8, or DC the vanco and keep the merom? And again, the correct answer is going to be C. DC the vanco and the meropenem and begin cefazolin. Now, what's your rationale for that, Greg? I can tell you what it is. It's based on if he truly has a structure-activity relationship. I know for the R group, I'm looking for a benzene ring. Cefazolin does not have that. And so from a structure-activity relationship and based on studies, the odds of that cross-reactivity are almost 0. So I'll feel safe giving him cefazolin. I would not call the physician in this case if that was the situation. I would go ahead and approve the cefazolin, would probably call the nurse and say, when you give the first dose, keep an eye on the patient. But if they did have a reaction, was it truly a cross-hypersensitivity reaction? Or is it that the patient also has a cephalosporin allergy? I think it's probably going to be the R group they have is also antigenic to the patient as well. The antibodies go after it because of a previous exposure to drugs such as cefazolin. But the answer would be D. So case 1, more of the story. So the attending physician, prior to changing the order, talks to the patient's wife. And he had some type of rash but was uncertain of the severity. So the attending decided to order a penicillin skin test. Probably a little bit overboard, but you know that's the way they want to go. So Based on the patient medication history, there's no contraindication to penicillin skin testing. So is that true or false? And the answer is false. And if you ask yourself, why is it false? That's going to be because the patient was taking Claritin daily, or Zyrtec, or Allegra, the fexofenadine, the cetirizine, you know the products that are out there, the loratadine. You got to let those have about a 5-day washout. So case number 2, this was an individual, otherwise healthy individual, shows up at the ED with appendicitis. Surgery's consulted. They take the patient to the OR for an appendectomy. They order the standard appropriate cefazolin, 2 grams times 1 dose is appropriate, plus metronidazole. That's going to cover all the pathogens we would want for an abdominal surgery for appendicitis. Covers MSSA, covers E. coli, covers Bacteroides fragilis, so it's all good. It's all good. Let it go. Well, pharmacy calls 10 minutes after the order and states, hey, they got an allergy. Could you all just give ertapenem instead? Now, I'm going to tell you, we have seen cases at Hendrick Medical Center where one-time broad-spectrum antibiotics, one time given, has induced C. diff colitis. It doesn't take a lot when you're talking about dysbiosis. So anyway, there is a risk there. Now, would giving ertapenem, would it really hurt anything? Probably not, but it's more expensive and the risks are still there. But for the sake of our discussion, is that necessary? Do you have to do that? And what would the physician, or what should he or she say? So sure, change it. What will it hurt? Second choice, no, that's what I want. The actual risk of a penicillin allergy being real for cross-activity is less than 1%. Besides, remember, this kid had a history of amoxicillin, but at the same time, they were diagnosed with mono. Mono will present initially like a strep throat. You give amoxicillin, you're going to have a rash. The key is it's non-pruritic. And it's certainly not a type 1 IgE-mediated reaction. Of course, I heard penicillin skin testing takes only 1 to 2 hours. Let's do that. You know what? If you go that route, just let them have the ertapenem, because that's going to slow everything down. But in this case, B would be the appropriate answer. Just give the cefazolin metronidazole combo. Give that combo. And then case 3, this is our 42-year-old gentleman which has some progressive dementia. He presents and is subsequently diagnosed with neurosyphilis, which we know the treatment of choice is penicillin. So what is your next step? Go ahead and give penicillin and just chance it? I don't think that's right. Perform a penicillin skin test, then proceed with therapy. I think B sounds pretty good. Patients should be desensitized to penicillin. Well, I wouldn't do C until B was positive. Then I would do C. I'd consult an allergist and actually do a desensitization. Or begin ceftriaxone 2 grams IV daily. Well, you know, when you think of ceftriaxone, could you do it? You could. Is 2 grams the right dose? Yes, but I'm kind of suspect of the daily. You'd probably want to treat that just as you do any CNS infection with the 3rd generation cephalosporin and do that Q12 hours. But anyway, the answer is perform a penicillin skin test. Will be done within an hour of the oral challenge within 2 hours, and then you can do pathogen-directed patient-specific therapy with your penicillin 4 million units every 4 hours. So the correct answer would be B, perform a penicillin skin test, then proceed with therapy. So that's the end of our discussion. Appreciate your time. Again, if you have questions, feel free to reach out. If you have any further questions about a penicillin allergy or penicillin skin testing at Hendrick Medical Center, please feel free to reach out to me at 670-5550 or by email at gperry@hendrickhealth.org. Thank you.